and go ahead and call to order this regular meeting for the Seneca Healthcare District Board. Roll call in the room, we have Rich and Sherry and Shelley and myself, and Ken Crandall is absent for today. Let's go ahead and rise for the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. That brings us to item number 2, additions, modifications, or deletions from the agenda. I just have one item. We are going to table item number 7, the GE mobile contract discussion for next month's meeting. Other than that, I have nothing else. Do I have a motion to approve the agenda? That change? I mean, thank you. Do I have a second? Second. Thank you. All in favor, Rich?
Aye.
Sherry?
Aye.
Shelley? Okay, that brings us back up to public comment, but I know that there's 2 public comments, or I just marked it the wrong spot. So, don't think we had any public comments submitted in advance. Anything,
I do.
anyone? Go ahead, Rich.
The Dixie Fire caused a lot of devastation and hardship to the Amador Basin community. I understand that the PG&E has given over $7 million to Plumas County. I'm not sure where that money is going. I certainly think that our board or the district here should indicate to the county that the devastation and hardship that it caused, that we should be able to receive some of the payment to take care of health and public safety that we're responsible for in this community. So I'm not sure the process to do that. What I understand is there have been some frivolous, what I consider frivolous ideas that have been published in some of the newsletters and newspapers. But I certainly hope that this district can convince those who are making the decision that the hardship that we experience here, that we should receive some of those funds, an appropriate fair share of those funds.
The Board of Supervisors is having a special meeting. I think it's next week, Tuesday, no, Monday. Or every part of next week, in Greenville for this specific purpose to discuss what should be done with the funds and where they should be spent. So it'd probably be good if somebody would go to that meeting and lobby for funds or whatever.
Okay.
But those funds that they're talking about primarily were to the county to replace county facilities and costs that we lost. So I don't know how much is actually gonna be left over after, for instance, in Greenville, they had to replace the sheriff's substation, the jail, this, that. Yeah, but they are having a meeting for public input for those funds, and certainly, Canyon Dam area and Warner Valley are affected. But more so, as you're saying, because we have to provide the healthcare and emergency services and actually we're during evacuation and everything else, probably the busiest people around other than the sheriff.
Cause we had to transfer patients down to.
Twice.
Get rid of
Twice.
SIP, yeah,
Gee,
Right,
yeah,
And then
So-
we shuttered the facility and then we had to reopen it.
yeah.
that's why I think it would be good to kind of somebody capable of speaking to all those issues.
Yeah,
Who could, cause if we just go say we just want money cause we're in a damaged area, everybody's damaged.
Yeah,
But if we can go and make a good case for the hardship that it was for us to help the community through that period of time, which we all know it was. That then, and have a use for the money. We would say, well, we wanna.
do you happen to know what time that special is?
No, but I can email it to you.
Yeah, I'll look it up as well, but I happen to be down in Quincy on Tuesday. So maybe I could work out going to the special in the morning if I'll take a look.
I think they're two separate,
Represent.
I'm thinking they're 2 separate days, cause a couple of people were saying, well, are you still gonna have the meeting on Tuesday?
Okay,
So it's making me think it's Monday, but I don't wanna
let
swear.
me take a look at that. I did reach out to Tom McGowan, asking him about the representation with regard to these funds for District 3. I didn't get a response, but I did bring it up to him verbally again the other day. So, I guess he said that there's just the specialist to listen to what the committee's recommendations are. There's a committee that was formed. Is that right, Sherry?
Yeah,
Okay,
that's the one I was talking
so
about.
no decisions have been made, just there's been a committee formed to.
Right, to try to
saw-
look at it.
I saw something about the fairgrounds and I'm like,
Yes.
Mamie
What?
made some
Yeah.
kind of a offhand comment, looking at various, she was thinking economic development, because we use the fairgrounds for evacuation center and large animal evacuation.
I see.
And all that kind of stuff,
Okay.
but it got so much pushback, because most of the public doesn't even think about that. It was like, it's not made to fix the fair.
Yeah, that
And
makes,
So do you know if
so they
they're,
backed off from that.
do you know if they're actually making decisions next week, or if it's just to hear the
I
recommendation?
think it's just to hear, to get input, because they've been flooded with so many people unhappy, feeling that they haven't had a chance
To provide it.
to provide their input.
Okay.
They hired some consultants early, well, I should say we, because I was on the board then, but we hired some consultants early on to look into use of the funds and trying to figure out where the images were and all that. But nothing really fruitful came from that, and it didn't involve the public.
Good.
So it's about.
so I'll make it if I can. If not, we definitely need to have some representation there.
Yeah, we'll figure out when it is and we'll see who's available to go, for sure. Yeah, thank you for bringing that up.
Thank you.
Rich. Okay, any other public comment? Anybody online? No? Okay, we will move on to resolution number 453. This is the resolution to name the North Healing Garden at the New Lake Almanor Community Hospital in honor of Dr. David Walls, and I'm gonna go ahead and read this into the record. Whereas Dr. David Walls dedicated his life to the service of the community, providing exceptional medical care and compassionate support to countless patients and their families. And whereas Dr. Walls is a beloved member of the Seneca Healthcare District staff. I don't know if I can read it.
Yeah.
Known for his unwavering commitment to excellence, his kindness, and his tireless efforts to improve the health and well-being of all those he served. And whereas Dr. Wall's contributions to the field of medicine and his impact on the community has left a lasting legacy that continues to inspire and uplift those who knew him. And whereas the North Healing Gardens at the New Lake Almanor Community Hospital serve as a great place of tranquility, reflection, and healing for patients, families, and staff. And whereas it is fitting and proper to honor the memory of Dr. David Walls by naming the North Healing Gardens in his honor, thereby ensuring that his legacy of care and compassion will be remembered and celebrated for generations to come. Now therefore, it be it resolved by the Board of Directors of the Seneca Healthcare District that the North Healing Gardens be hereby named the Dr. David Walls Healing Gardens in recognition of his extraordinary contributions to the hospital and the community. Be it further resolved that appropriate signage be installed to reflect this dedication. And with that, I will open it up for discussion.
Absolutely, I think we should, at a minimum, do that.
Yeah.
And certainly add everything that is in here to how I feel about how he served our community. And the stories I've heard over the last week or so especially, so I move approval.
Thank you. Do I have a second?
Second.
Thank you. All in favor? Rich,
Aye.
Sherry,
Aye.
Shelley?
Aye.
And I'll vote aye. Thank you. All right, that moves us into Sean's report.
thank you. I appreciate you moving me up in the agenda. We've got the event tonight, so I need to bounce out of here a little bit early. Just a little construction update. I'm sure Donna will do a better job than I do. I just want to give the board sort of my bird's eye view coming out of my window every day. So we completed our 4th footing pour yesterday. That is the final one for the footings. There's going to be an additional footing pour, but it's more for the, what do they call them, the canopy support beams. So that's going to be going on. We'll be moving into June. We'll be doing the slab. I walked out there today. A lot of the underground is being done as it relates to power coming up and the sewer and water maybe coming up. It's been addressed with granite or gravel, and it looks like it's prepared for slab. So there will be 4 slab pours. 4 slab pours. So in June, you'll be seeing the slab developed. And after that, shortly after that, in July, we'll start raising our steel, and it'll be just a rush to get the steel up, wrap the building, get the steel, the plating, get the roofing on, and chasing winter, right? Is that the case? Done any? Okay, so we think that our events that are coming up are gonna be really well served with the amount of work that's being done out there and the actual visibility of what's happening on the plant. I would say that they are moving quite quickly. We passed every inspection. but they have to do an inspection prior to every pour, and there's been no issues. So Donna, would you say we're tracking really well?
All is good.
All is good.
Yeah,
Okay.
I feel like we've got good support from HPI, which is not always the case. So good.
So moving right along. Very good for that. Want to take our attention over to, there's been a lot of talk about Medicaid, what's happening in Washington, DC with the bill that's now going to the Senate as it relates to Medicaid. The rumor is that Medicaid is still at risk, but I was reading an op-ed that Medicaid is more at risk as it relates to the fraud in Medicaid that's happening. And I'll give you an example. It turns out that there were people that were enrolled in Medicaid in multiple states, multiple joining states. This accounts for billions of dollars in waste. So this is the kind of stuff that's starting to get overturned. The problem that we have here in California is that we know how our legislators and our administration in the state of California get along with the current DC administration, specifically as it relates to undocumented workers. So I do think we're still at risk in the Medi-Cal space to have the Medicaid federal dollars dry up a little bit. So we're still paying very close attention to what's going on. I don't think we're out of the woods. More in California, I think that just because of the disparity in philosophy between the two administrations. I did see where the budget deficit for the governor's budget deficit was quite much larger than expected, and there was discussion about how to alter the Medi-Cal project, or the the Medi-Cal benefit, to align it a little bit more with permanent residents and stuff. So it's shaking the tree. We're just paying attention to it, guys. There's just a lot going on.
So you're
And
saying
no one's out of the
you
woods.
didn't get the feeling that the state would partially or fully backfill anything lost from the feds?
And
That's kind of what I'm,
it's
that's what I've
billions
been
of
hearing.
dollars. It's a lot of money. And I don't think that, we're already in a deficit. I don't think they can backfill the Medicaid, the federal dollars.
That's
So,
what-
we're paying attention to it. It's 30% of our 22%, 26% or something like that of our payer mix. So it's important. So paying attention to that. Tons of state legislation on the table. I mean, just the bills have been rolling in hot and heavy. None of which are favorable. I mean, very little, the MCO tax thing, it doesn't look like it's gonna get pulled into the budget, the MCO, which is just not gonna be used for what it's intended to be used for. So it's gonna be an interesting legislative year in the state of California. Lots and lots of stuff that is union backed and has a real negative effect on health in a lot of ways. We're gonna be tracking a lot of stuff like that. Mobile MRI, we do have the completed MOU. It's been approved by legal, and it's gone out to all the CEOs, the 5 CEOs of the 5 hospitals. That MOU will be on the agenda for your review, comments, and approval, or your vote to have me sign the MOU. It will be going to every board in June, all the 5 hospitals boards. Along with that, we just tabled number 7 will be the GE contract that has also gone through legal. Back and forth, so that's if we have a final ready to,
What's the GE for?
it's for the mobile MRI and coach.
Okay,
Now, I will say that Seneca is going to be named on the contract. That's why the MOU is so important, so you can read, we may be named on it, but there's a lot of culpability and responsibility for the other 4 facilities in our MOU agreement. We're also gonna probably end up being the managing authority for 5 years on that, which means that we will be responsible for making sure that maintenance is done, collecting the money from the other sites and things to that effect. There is remedy in there in the MOU that you can pay attention to. If they don't pay, please take a look at that, and that'll be on the June, for the June board meeting. And I highly recommend that the board approve this so we can move forward, but we'll get to that in June.
do we get services that have reduced costs since we're the managing authority for 5 years?
Do we?
Uh-huh.
No, we pay equal share. There is a discussion in there about a small percentage that goes to the managing authority. Take a look at that. It's nominal. But we'll be doing that, so that's a big one coming up.
So Sean, will that nominal amount cover our costs?
Yeah, for overhead, yeah, everything's there's gonna be a percentage going into an escrow account that can be drawn down. It's just a matter of when we draw it down for any administrative reasons, then we just have to notify the other form that's being drawn.
Is there a target date, start date?
Yeah, we want to, so with Heritage, which is the immobile MRI that we've been trying to get here, and they're going through the regulatory requirements for the state of California. Their contract started in January, correct? Their contract is 2 years, 24 months, so 6 months have already been burned into that contract with no service, and it doesn't say anything about first patient is when the contract starts, it's the date of the contract. So we have roughly a year and a half left on that contract. We are going to put our order in probably early spring next year. It takes about 9 months, and we'll receive delivery at the same time that we're rolling out the contract with Heritage. It's all gonna be about timing.
So we won't have MRI then until next.
No, we'll have MRI under Heritage, which is
Heritage.
a third party
Okay.
vendor,
Okay,
as soon as they can get through the regulatory requirements.
Yeah. Linda, if you can hear what you sent an email today about you talked with Caesar and CDH, is that correct?
Today, it was fortuitous that we had HCI here on site for the project. So while Mr. Greg Paul from HCI, the Fire Life Safety Officer, was here, I grabbed him and had him do the fire life safety inspection for the location of the MRI, which Mr. Paul signed off. So now it's a matter of waiting for Heritage to get their insignia number, and Mr. Paul will complete the paperwork, and we can submit it to CAB to do our change in equipment, and we'll be good to go. So I was just trying to speed the process along.
Thank you, Linda.
Thank you, Linda, that's great. But they do have to get through CDPH. And we are gonna be able to help them out, I think, considerably with CDPH. So-
Okay.
So we're trying to get our MRI service back up, very important to us. Okay,
thank you.
I'm gonna stop there, just take questions, unless there's no other questions, and
Thank you, Sean. Any questions for Sean?
no,
All right, you running off?
they're run off. Thank you so much.
Thank you, Sean.
Thank you, Sean.
All right, so that moves us past 7 into number 8. Approval of the April 24th, 2025 special board meeting minutes. And board members, if you've had a chance to review, I will take a motion to approve.
A motion to approve.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Shelley?
Aye.
Sherry?
Aye.
Rich?
Hi,
And I'll vote aye. And that brings us to item number 9. Approval of the April 24th, 2025 regular board meeting minutes. Do I have a motion to approve?
approval.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Rich?
hi.
Shelley?
Aye.
Sherry?
Aye.
And I'll vote aye. All right, so that brings us to our staff reports. In the interest of time, perhaps I'll ask if any board members have any questions, or if you want to make any highlights of, because I think yours is up first.
Yeah, that's fine. Let's just go with, you can read through this, a lot of good work is going on here.
Mhm.
But in the back, we put new dashboards. And so I put sample on the one, so it's like you guys can say, I like this, I don't like this, like we did last time. There was a lot of questions on partnership health and
Yeah.
what's the total patient load plus how many do we get per month? So there's a graph on that. Candace creates all these graphs. And she's our clinical for the analytics. So that's this report here, so just digest this and that's what we do, and then we call them and get them established and do the process of that. When it comes to capacity and utilization, all of these other charts are in that same zone. So this is a utilization of like you can see how many our specialty or primary care, obviously, we're loaded in the primary care realm. So this chart may be helpful, may not be helpful. Then when it comes to the next chart, the following page, where it's appointment types, it's interesting information. And so, but it's broken out in minutes and times and stuff like that, so if that's something, and you don't have to say yay, nay now, we'll bring it back next board meeting, that give you time to really do what you like. And then, when we get down to the visits, this goes into the different pods and the different providers. And then how many, how many visits are doing monthly. It also talks about, we have one provider, I think on the next page, out, so where the patient load went, because that's a question. Too, so you can actually capture that thing.
So- Brady, one question.
Yep.
So on the clinic visit data analysis, that chart there,
Okay.
will you spell out what is clinic A, clinic B, clinic C, clinic
Oh,
D?
yeah.
Okay,
And then my question on that one was, if I see PCP one in clinic B, but also in clinic E, is that the same provider or is that a different provider?
One,
yeah, one and E,
so,
clinic B and E.
that's a good question.
Yeah. And you
So,
don't have to answer
it-
now.
Well, clinic E is the walk-in, so they rotate through there.
Okay,
So, but I'll check on clinic B and clinic C, unless they move, but that might have been, let me double check on that.
just curious, trying to figure out whether those are,
Yeah,
one
and
provider.
then we decided it's better not to put names, just so that you can see from an analytical standpoint to know.
I think that's fine, board members. Is that fine?
If there's a huge variance, we'd probably be asking you for.
Yeah.
Yeah, we can always
Yeah.
ask.
And so then the next page, just displays, patient seeing how many days the providers, and you can see like provider PCP 6 is, orange is days in clinic and patient seen, so you can probably guess who that is. But that's kind of how we can measure it, and it's all from the normal January to April timestamp. And then when it goes down to total patients seen in clinic days from a roll-up perspective, that's another way to look at it. So there might be too much data, but if you guys want to look through it, say we like this, we don't like this, or tweak this, then we can add this to our deck when we do a quarterly analytics.
Yeah, so board members, if you don't mind taking a closer look, if you haven't already, and then provide feedback directly
Yep.
to Brady.
Yep.
Then that would be fabulous, and then we can kind of work on the iterations. For me, no data, no amount of data is too much data, but maybe for other board members, I don't know.
No, I think it's helpful. I have a question though, on the percentage of total no-shows. I'm interested in the no-shows.
Yeah,
I've
so
never
am
seen
I.
those kind of figures before.
Mhm,
The PCP 3, that
mhm,
was at, what, 25%?
mhm.
Is that no-shows of scheduled patients?
Yeah, that would be percentage of no-shows, but then you can also see the volume of PC three, so there's a higher volume.
Right.
Yeah, but, I could possibly break that down.
It's just kind of
Why? You wonder why?
so strikingly higher than
Yeah.
everybody else that you
Well,
call
I
out.
could break that down because if it's, no-show, can't, there's a couple ways they call before and they cancel, or they physically just don't show up. So we could probably explode that a little bit. You could
Yeah,
see,
because to my question was it yesterday about whether the construction is
Yeah.
impacting us, you know?
well, yeah, and the providers have now, I mean, if you're within the first 15 minutes of being late, that's somewhat acceptable how busy they are, but if you're beyond that, it's rescheduled. So,
And then that would count as a no-show for.
that would count as a no-show.
I think it is being influenced by that, because when I was here the other day, a couple came in, the lady was very hot under the collar, she was coming from Susanville. And had gotten stopped at all 3 of the
Yeah.
construction, and each time 15 to 20 minutes. So they were basically telling her, we're really sorry, but you're so late, we can't put you in.
Yeah,
And she had an appointment again at 1 o'clock for herself, and finally she said, well, give my son the 1 o'clock and I'll reschedule. And I got to thinking at that time that that's got to be a big impact,
Mhm.
Well, I wonder-
especially if we're seeing the volume that I think we're seeing coming from that direction.
Yeah, and what we try to do is, depending on what they're here for, is roll them into the walk.
That's what I was gonna
Yeah.
ask, is it, yeah.
The walk-in was full.
Oh,
I mean,
yeah.
there was no waiting chairs there. Everybody was full.
Yeah.
It was a real busy morning.
Well, I'll explode this and see if I can show it a different way.
But why it would show up more for one position than others is,
Yeah, unless
Really
it's total
interesting.
fault, yeah, but
Yeah.
I'll do some research on that. Okay. And any other questions?
I have a little off topic, but in Sean's presentation about what's going on with Medi-Cal, or what may go on with Medi-Cal, is there a way we could figure out how many of these patients are truly at risk?
Yeah, I was thinking that too, you could, well,
Depends on what the end result is,
Mhm.
because it could be any number
Well, we kind of have a sense of what California is talking about.
yeah, we could probably take the California percentage, like whatever the percentage of the population falls into the category that's at risk, and apply that number to us. It wouldn't be accurate, or it wouldn't be as accurate, because we don't know if that population is the same population that qualified, but we could do some, just a risk. Just to see what the impact could be if we were just like, all of California, yeah.
Thank you.
of. Thank you, Rich.
Considering that 22%.
Any other questions for Brady? All right, let's see, moving on, I don't think Brian is on this. Did you have something to highlight? Ethan?
I have a few updates.
Okay, go ahead.
Hi, everyone, so just going over some of the major things that happened in the last month, we did have a domain I-wide Cerner outage on the 22nd. Rollback downtime, we're gonna be going over the policies for outages, with the different groups, just to make sure that when that happens, not if, when that happens again, everyone's prepared for that.
Are we gonna do any drills?
I don't believe we have any plan, but it's certainly been mentioned.
Judy and I are talking about that, yeah.
Great ones.
Additionally, projects that have actually come to fruition, the butterflies have been deployed. We're currently waiting on provider training. We're gonna be trying to sync that up with, med staff, next med staff, just to make sure that we hit as many providers as possible with that. But they are operational for the doctors. They're already trained with it, or providers for. Interpretation laptops, those for tablets, those have been deployed. We have now 2 interpretation devices for the clinic and 2 for the hospital, so those are fully operational and have been used to great success so far.
I've heard the feedback on them.
Yeah, we, the day after they were deployed, they were able to be used and it worked like a charm, so that's been going good. The big one, Windows 11 upgrade, we've been talking about that for a while. We're approximately just over 60% integrated with that. Almost all of the clinic is complete, and now we're moving on to scheduling the hospital, doing it blocks at times and not to have outages. Earlier today, we went over the budget for IT. That's ongoing, but made good progress with that. We can break that down into parts if anyone is interested. And then, within this last month, we've had 33 SRs open and I believe nearly as many closed, so we are on track with that, pretty standard. So are there any questions for IT?
I have a question, but I don't know if Judy's not involved. The butterfly. What are our planned usage for that? I know we have the emergency room docs will have them. Nurses gonna?
Well, you can, yeah, you could, so clinic, so we have a total of 3.
We do.
One's gonna live in the clinic, one's gonna live in the ER. So the providers can use them, the nurses could use them for IV starts, you know, there's all of these. Techniques that you, depending on how far you wanna go with it, that you can use those. And that's when they're here, we're gonna have our ultrasound tech be the super user, because that's what she does, so we're gonna train her as the super user, and then Judy can decide what she wants to do, how far we wanna go, because they're pretty cool.
They are. So maybe at a future meeting, we could,
You want?
hear,
Yeah.
just hear about you know,
Yeah.
what our
Will do.
experiences. Thank you.
Yep.
Thank you.
Appreciate it. Okay, so now that brings us to Shannon. You're, oh, there you are.
I'm hopping around. Okay, so continue recruitment efforts for LVNs and CNAs, not getting a whole lot of applicants, unfortunately. And if we do, they don't communicate back with us. So still working on that. HIM and admissions has 2 openings, so we're interviewing for that, hopefully get those filled soon. Let's see here. So we posted the director of IT. We've gotten over 100 applicants that Brady sorted through. We have 2 phone interviews with Brian. Brian's going to talk with them next week. And then we have an internal candidate as well, which is good. Our PT is expected to start mid-August, so he's in the onboarding process. And controller, just spoke with her today, it's sounding probably like mid-July, early August, so that's on track. And then for physician recruitment, I have a potential candidate coming on site the 6th and the 7th. So that itinerary is all booked and ready to go. That one came to us directly from a recruitment firm. So that's not due to our internal strategies that we're doing. Chelsea has been working on the postcard and a letter to be sent out. Sounds like that's gonna go out early June. I signed up for Doc Cafe, May 19th, provided some statistics. That's only a week's worth, so they have improved since then. Yesterday I got signed up for Practice Link, so working on that. As far as Doc Cafe, out of the 430 emails I sent out, the statistic for that is 52% had opened that email. So that's good.
That's
And
actually really good.
yeah, I didn't see that when I was preparing this report, but I saw that afterwards. And what I'm doing is some have opened it more than once. So on those ones, I'm doing a follow-up email to see if they have interest.
So Shauna, the family practice doctor that's coming on site June 6th and 7th, is that for a full-time position?
Full time, yeah. Brady and I did a phone interview. He seemed good, so communication was good, well liked.
Yeah, he's in California, is a concierge type practice now in the Napa area. Has been up in this area because of friends. And his wife is also a physician, but she's retired, she's a neurologist. But yeah, the phone call was a very good phone call, so we'll see how all of that stuff.
So progress.
Exciting.
Great.
Yeah.
Any,
Progress is good.
yeah. Any questions for me?
Thank you, Shannon.
Yeah.
Okay, that brings us to Chelsea's, and she's not here right now. I don't know if anyone had any questions on Chelsea's report that maybe we wanted to run. No?
No.
Okay. Thank you, and then compliance will be in place, so that moves us on to item number 11. And Steve, I think, if you don't mind, maybe hit a couple highlights from March, but maybe focus more on the April. Thank you.
Highlights.
We're good. Sorry, Ken's not here. We're kind of. Just burned all on the slide. We're not urban also part. Brian is not here.
Well, that is
Okay,
kind of the
there
highlight.
it is.
It's moved to May.
It's- Are you running it too, Ethan? Yeah, let me grab it, let me put it on a new tab for you.
You guys fight each other.
Yeah.
Now's the worst. Now's the worst, yeah.
I got control. Thank you. Okay, just quickly again. You can start, let me just jump. Okay, just. Highlights from, bless you. Highlights from March, revenue, negative to budget, both inpatient and outpatient. Total revenue, negative.
deductions of revenue positive, both because the decrease in revenue and we had a little higher net revenue percentage, lower deduction as a percent of revenue. So we were negative on net patient revenue, 51,000. The inpatient revenue, we did have higher acute volume, we had higher swing bed volume, or we had some volume, but it did not meet budget. Going down to expenses, kind of the high salaries and wages. Very similar to what we've experienced the last few months, we're on a pretty consistent pattern with expenses, salaries and wages, over budget, contract labor, professional fees, medical, which is a labor related cost, mainly due to, again, the 70-wide conversion, going from Steve Hayden as a contract basis to Stephanie on an employee basis. That was positive to budget. The rest of the expenses were pluses and minuses. Our overall expenses were, did I do that? Okay. So, I see, be careful. No, I got it.
Here, we're leaving.
No, I got it. Wait, swinging my hands, or it shows when I need to stop. So negative to budget, income from operations, negative 65K. Non-operating expense, positive, interest, income mainly related to the, interest we're earning on our, interim financing funds unspent or undrawn upon. And bottom line was a loss that, was negative to budget, just a little bit under 40,000. So kind of a good month. Again, our big dilemma, our big challenge is revenue. So I'm gonna jump to. Actually,
Would you like me to?
yeah, Ethan, why don't you include I'm good with that part,
And we're gonna go ahead and maximize this so that it's.
get that out of there.
Yep.
Okay, so can we, any questions on March? That was obviously real fast, but it's pretty straightforward. Revenue under budget, operations, bottom line. Under budget or negative to budget.
Yeah, Steve, hold on 1 second, please. With that, I will accept a motion to accept the March financial report.
So moved.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Rich,
Aye.
Shelley,
Aye.
Sherry,
Aye.
and I'll vote aye. Go ahead, Steve.
Okay. So this is the, till I get caught up, with presenting the next month financials at board meetings, I'm gonna, provide this. If you guys see something that's not in here that I can provide, basically the only thing I don't have is the non-labor expenses. So, I can pull together anything from a statistical basis, from a revenue basis, cash, AR, just not the non-labor expenses. So if you don't see something here, I can certainly add it. So for the month of April, this is, we're expecting that we'll have a better report than March, mainly here because we had, net patient revenue that was positive to budget, $11,000. You can see the components of it. Let's see. I'm going a different way. There we go. That the inpatient revenue, although improved, was still negative to budget. We had better performance in the acute area. We had 19 inpatient days. I was off 3 admissions, so those were a little longer length of stays than normally. You know, a critical access hospital overall needs to have a 4-day length of stay or 96 hours. Yeah, 96 hours. And
Steve, were those partnership issues?
I'm gonna keep talking, but I can pull that up.
Okay.
There was one patient with an 8-day length of stay. Can't remember.
And so your long-term census has stayed pretty
Mhm,
consistent too.
Yeah, long terms, we're basically full and then, you know, have a discharge. And then we build a bed, we do have a waiting list, so that's a really.
I'm just considering the acuity of partnership patients overall.
Yeah. Sorry,
Swing bed, was that probably a partnership patient?
no, they're almost always Medicare,
Okay,
very rarely is it a non-Medicare. We've had a couple where, Blue Cross commercial insurance, but other than that, it's all Medicare, which is why it's another reason it's a great business, cause we get
Right.
cost. So it pulls more of that acute cost into the Medicare cost report. So,
Thank you for putting this together, Steve.
yeah,
Very, very
I
helpful.
mean, everything's there, it's just that last piece we're missing, and of course, even with the information, it's been tough with the budget, but,
I'm just considering that as the state of California has these issues with. Well, like, all United States, with Medicaid and Medi-Cal, usually the acuity is higher with many of those patients. And what do we stand, what's our risk?
uh, April was an interesting month. The longer length of stay patient was a commercial insurance patient, inpatient. Had a length of stay of 9 days. We had one Medicare for 6 days, and then we did have one partnership for 5 days, so all of our inpatients exceeded our normal 4-day length of stay. We do run interqual on all of our patients, so we don't bill them if we don't meet interqual, if they
Right.
fail to meet interqual, but we can't discharge them for whatever reason, no safe discharge or who knows what, it's the weekend.
Yeah,
The
does partnership pay us better than the Medicare DRG? I don't know what our contract is like.
partnership doesn't pay us better than the what we get paid for Medicare under cost. You know, what the DRGs pay, honestly, to tell you the truth. But they do pay. Maybe I haven't looked at it in a long time, but partnership, I was just looking the other day, because we got a really nice check from them on an inpatient stay. And they're paying us over $3,000 a day, which is a pretty good rate. That's a reasonable rate. Medi-Cal usually was around $2,000 a day, so it's $1,000, but still adds up.
Okay,
So,
and that's for inpatient, acute,
that's
not ops.
correct.
Okay.
That's inpatient, and that's per day for everything, you know, so all
Sure,
inclusive.
all inclusive, yeah. Okay, thank you.
So it's a per diem rate.
Interesting.
Yeah, and again, our our actual Medicare cost is way higher than that. Just because our days are so low,
Mm-hmm,
you know, we're just,
mm-hmm,
and we have such good fixed cost, which is part of our dilemma. When we look at our financial statements, we have all of this fixed cost, and if we're not generating revenue from any source, you know, from any particular source, this is problematic for us. So, inpatient improved, outpatient was positive, total patient revenue was, slightly positive. Deductions were, you know, kind of a wash, kind of right at budget. And so, like I said, we're probably looking at a little better, we're certainly looking at a little better month than March. Down below, like we talked about, the long-term care days, we're essentially running a full house. In the month of April, Brady already talked about, the one provider that was out, and we see that in the clinic visits. So having outpatient be positive, revenue wise was a good thing, because we had a big negative variance on the clinic, just because of the visits number, and also the continued, that we don't have MRI, where we budgeted for it, so the rest of outpatient ran really well. ER visits are pretty consistent with the prior months. Just a positive thing, at least in my mind, is our revenue went up in April. But our accounts receivable stayed at the March level, and so. That's a good thing from our perspective, is that our revenue went up, so we loaded AR with more revenue in the month of April. Which we really are not gonna collect. A high percentage of in the same month. But we kept the balance, which means we collected older stuff, and so we're starting to see some movement on, we're starting to see some good movement within the AR. The cash on hand stayed pretty consistent with March to April, and then FTEs were just up a tick. In April or March to April, with the hourly wage just up slightly. So. Questions about April?
Board members? Steve, this one's really informational only, right?
Yes.
Yeah, we just put it in and I run it after, I read it after the March financials, so it kind of falls under that approved, accepted category, but
Hopefully.
there's really nothing
Okay,
for.
I just want to make sure. before we-
Yeah, it's in the information, so,
So this is temporary until we get caught up.
yeah. That's you.
Thank you, Steve. So that brings us then to our cash flow.
Yep. Okay, really the only update from, two updates from me is that, we received our H2AF supplemental payment last week, the $1,053,000. So we've received all of our supplemental payment in this fiscal year cycle, which is great. And we're done with that, and our cash, our cash days are back. They're at 88. They'll be at, they're 88 for April, and then they're gonna go up to 108 into May. The only other thing that, additional or outside of operations thing we have to collect is the second installment of the property taxes next month, which will be something around $300,000. The IGT, which is reflected in the month of November, just heard from DHLF today, that might get moved to October, which would really be great. That helps. That means we could get our supplemental payment by December. Those numbers, those IGT numbers are set. We have them in contract. I don't know. How the Medicaid changes or proposed changes are gonna affect something like what's here, because we have contracts signed. I guess they have to go and say your contract's not valid, or your contract needs to be revised. I don't know how they're gonna change that. But these numbers are supported by signed contracts, and then the supplemental payment that we'll receive a couple months thereafter represents about over $1 million increase to what we're currently receiving this year. So hopefully that stays in place. That's about all I have on, I did speak with Western Alliance Bank. They are going to look and see what it would take to turn on the line of credit again, so they'll give us an idea of what the cost would be. See if that's something we want to get into. I also have an answer for you, Donna. The takeout. So that's it. Questions on cash flow?
Board members, questions, comments?
Thank you so much.
Sure does. Thank you, Steve. You want us to accept the cash flow report?
Please.
All right, do I have a motion to accept the cash flow?
I move.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Rich?
Right.
Sherry? Shelley?
Aye.
And I'll vote aye. Okay, so that brings us to our April 2025 R1 life cycle report.
This one? That is it. So we've talked about this a lot. We actually had representatives from R1 here today. They're sponsors of our golf tournament. So that was nice.
Good.
So they came and joined us for the revenue cycle meeting. We asked Jerry and Rich from my treasurer's group to join us. And they did some presentation, some analysis they've done, and we talked about the April report a little bit. One of the things that I think that we talked about, and we just want to emphasize here, what is this? This is the combined scorecard. So can I get this thing to work now? Just, you have control. Okay. Okay, so right there, the total insurance days line is, as you can see, it's gone in January from 77 down to 59.9. That's not all just pure performance. There was a big account in there that got settled, but it's also performance. So what we're talking about, and we've talked about in previous meetings, is that we know the issues surrounding self-pay. We talked about it a little bit more today. And where we're proceeding with. And we'll get there, we have some comments about it, but the real thing for us to focus on is the total insurance AR, the third party AR, because that's the stuff where we're submitting a claim to a third party. And that's where issues with anything with our billing. Whether it's
Water.
our bill, whether it's, you know, our coding, whether it's anything. That's where issues within, again, our billing process come out. The fact that we're now down to just under 60 days with a target of 45 is incredibly encouraging to us. So, down, so we go.
That's a lot of money, 4.8 million.
Sorry, Ethan, can you go back up to that bus?
Absolutely.
Okay, there we go.
Actually, is it 3.1? 3.1 for total insurance AR. Yeah, 3.1, still a lot of money.
It is, and where we see money sitting, or certainly AR sitting, is in our insurance over 90 days. So there's gonna be a focus there, because when it goes to 90,
Yeah, million.
over 90 days, something's wrong. You know, yes, we can understand it going beyond 30 days or whatever, 30 to 60 days, that's kind of what you would expect. But when it gets over 90 days, there's definitely something wrong with it, so we need to know, is it just?
Yeah,
is
are
it
we
just
still having Cerner issues?
Somewhat,
The coding and all that?
somewhat. We are down to self-pay aside. We're down to a few remaining issues, and we walked through them. It's the big thing is that not every payer pays the same way, and so the way that Cerner is set up to do things automated, and so we have to write rules. So for Medi-Cal, you do this, for Medicare, you do this, and those are the things that we're working out, the final pieces. We have what we call workarounds, where we go ahead and we'll manually touch the claim. And today was interesting, because they said that some things we just let go and we let it deny, we bring it back and then we fix it. And so that was interesting, that on some things we just do it that way. We apparently can't just manually fix it, so.
That's leaving money on the table.
Well,
And with Brian leaving, I'm a little concerned about that because he did mention that there were Cerner, part of our AR problem was related to Cerner
Right.
programming, so.
Yeah, so what we're doing, Shelley, is, if you don't mind, you guys, is that we're kind of taking a trend with Brian leaving, we've talked with Brady and his IT, the IT team, and we're kind of doing a transition here where, previously, what we would have is on Tuesdays and Fridays, we would have Cerner meetings. And that's when we would go over all Cerner issues, anyone could come in and say, hey, this is what's happening to me, can you blah, 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 blah. And, then also it's where we would track these SR, the service requests, where things we've actually put into Cerner where we need them to touch the system and fix it. So what we're doing now is the Tuesday and Friday meetings are gonna be a all-encompassing IT meeting where we're not only gonna talk about Cerner, but we're also going to talk about IT projects, whatever those may be, the myriad of things that they're doing out there. So we have Monday, Wednesday, Friday, we have two meetings on Wednesday, revenue cycle meetings. So what we're gonna do is we're gonna move the Cerner management into one of those revenue cycle meetings. We believe it's gonna be Monday, because that's where the one meeting that we have the least demand on time for what we've been dealing with. It was mainly the charge master, and we got the charge master in pretty good shape, and so they're just little onesie twosies here and there. So what we use the rest of the time for is what we're calling an SR committee. And that's where we're gonna manage. Finance is gonna manage the Cerner issues and then work with IT to get them resolved. But we don't wanna put that on them to determine what's needed, what's done, what's happening.
Probably a good approach.
Well, and it's more of a team, kind of a team-based approach now with the IT team. Bree, so each, Ethan, Bree, Sarah have different skill sets and different disciplines. Bree is the one that is taking on Cerner and helping with finance, closing SRs, working SRs and all of that, and she's been growing into that since she transitioned, so I think we're gonna go through our recruitment process and all this stuff, but the current team that we have, when Brian leaves, which is last week is next week, we are still gonna retain him so we can get a whole things that the team needs. But I think between Steve's group and IT's group, I think we can continue on and make improvements and focus on what we need to focus. Patient care, obviously, first and foremost, right after that, finance.
Yeah.
Unless Steve goes, focus on this, then it's finance.
Okay.
We did Sarah, our revenue cycle coordinator, did a really nice summary for today's meeting. So if you would like me, is, not that we need to talk about it or anything, but just something for awareness for you guys, we can give you updates on the stuff that we're chasing. And at least I can certainly add that in, it's easy enough, it's like one page, The other thing is that we've now, IT was able to provide access to the CERT portion of Cerner, which is where the testing's done on modifications or whatever it is. R1 can go in and do that now.
Oh,
So that was a big,
that's great.
that was a big enhancement. So getting them that, then they can go in and do it. They don't have to,
They've been trained, they know how to do it.
yeah, that's their bread and butter. That
Okay,
they definitely know that. So
great.
And so Steve, are you guys prioritizing your SRs then, or prioritizing your issues and then translating those into SRs?
yeah, it's what we've done with Cerner all along is that theoretically, when you submit an SR, you put a priority on it based upon the impact to your operations, you know, it's not, everything's not financial.
Right.
There's like clinical ones, well, we can't provide patient care, so it's a, you know, you've got to deal with it today, kind of thing. But if there's a financial thing, we determine the dollars at risk, and we actually would submit sometimes, like when we lost our interface between our building, our clearinghouse. You know, we're saying we got $300,000-400,000 worth of claims sitting there that are not going across. This is a critical thing that needs to be dealt with. So we do the same thing when we look at something, what is the impact to us? So,
I was just wondering if, when you guys review your list of issues, if the priority ever
Yeah.
gets revisited.
On the Tuesdays and Fridays.
Yeah, that's what I was wondering.
Cause there'll be Cerner, we go over Cerner first, and we color code it based on that algorithm of the impact their cost patient. And then in the Atera, which is our ticketing system, and that is a system that we put in last year in the IT budget, we reduced Apex scope. And so those are some of the tools that our current IT, our system are managing. And in there, we have priorities, so we're focused on what is the biggest impact. for
So
us.
management's making that decision on the priority. level,
Yeah,
not-
yeah, oh, yeah. And we're reviewing it as a team because what's important to Judy, you know, is important, it's clinical, but when that interface didn't come across, that was all hands on deck too. You
Yeah.
know, and sometimes we have to quickly because of that impact.
Thank you.
okay, so without going into the pages and everything, just one thing you look into the materials and you look at the dashboard for the clinic itself. Our insurance AR days are under 40, they're 39.9. And that just, we talked about it today, just so many people had a hand in getting the clinic right. It, you know, it was everyone that was in the room
Yeah,
earlier
there's
today.
definitely been a lot of
Mhm.
improvement, and after today's meeting, especially too, I was optimistic that we're gonna continue on that path, because it sounds like we're on the right track to continue improving those numbers.
Right, and the last thing I'll say is, there's a slide in there that talks about, it's called payment mix, and it just shows the payments we received by who made the payment, Medicare, Medi-Cal. And self-pay, and our self-pay. For the last 4 months, payments have been very strong, people are paying their bills, and so that's really important, statements are going out. They're paying them, which means that they're not having major objections with what they're receiving because they're paying it. And once we get the tunnel built between our regular initial self-pay cycle and the transition to collect, then those, maybe people will react to stronger statements in their billing notices or the dunning statements. That's what Cerner calls them. But right now, medical debt no longer goes on credit reporting, so. All that sending them to collections does is it puts a more aggressive person on the phone, and they're getting calls, and they're just, they can still say no. And then frankly, there's not a consequence, at least in my mind, there isn't to that, so we'll see how that goes. But
Would you like me to go to the payment next?
no, that's, I'm just talking, so we don't spend too much time on it. So that's it, and we'll put together something about where the Cerner build and issues stand. Along with the R1 report. It's a great idea.
And, on the IT reporting, so we're gonna wrap that into my reporting, so we can put an SR graph, you know, so you can see into that a little bit.
That would be nice.
Or this, you know, most common or stuff like that. So we have a little visibility on that.
That'd be good. All right, Steve, thank you. There are interim financing.
Yeah, it's a standard report. The only thing of note is that we made the payment on outlay request date, which was the February request. Donna we'll have more conversation about future payments for the library. Other than that, it's just the regular presentation and information.
Great, thank you. Any other questions for Steve? Thank you, Steve, appreciate it.
Guys.
So that moves us right along to number 12, Donna, the new Critical Access Hospital Skilled Nursing Facility request 005 for contingency usage of funding plans with the USDA.
Yes, so, yeah, if we can open up that first memo. And, that has the detail of the 4 items that we're asking for, bringing forward to USDA for approval. They have gone to executive and strategic planning, and so we're bringing them to board to then bring to USDA upon your approval. The first one has to do with, the first 2 have to do with reconciliation of the costs, for, increments 1 and 2, the bid out, drawing, bid out drawings that were in the process of being permitted. And so, we knew that there was going to be this reconciliation, once we got the permitted drawings and asking the contractor to do any comparison between what they did and what ended up being permitted. So none of the items were voluntary changes, they were code required changes that, have been reviewed by both me and the architect of record to determine that they are valid, requests from the contractor. The third one, request number 19, is as a result of an alternate roofing system generated by the need to make sure that we're getting dried in for this year, so that we can work through winter. So the contractor to that end made the request to change to a mechanically fastened roof instead of the adhered roof, and it was reviewed by both our waterproofing, our architect, our waterproofing consultant, and our commissioning envelope consultant. And they all are comfortable with recommending this change to meet both the need of the schedule as well as making sure that you guys have a solid solution for your building moving forward. And then lastly, the $4,500 is for something that we've been tracking from for quite a while. We knew this was coming down the pipe with a $4,500 cost to North Star. We just got the actual invoice, so that's why we're putting it forward at this point in time for approval to get that processed. I think with that, I'll take questions.
Questions for Donna?
You wanna hear my contingency speech?
Go ahead.
One thing I would appreciate as we go through this whole process, each time we have a contingency request, is if we could get a figure of total contingency spent today.
Yes,
idea.
yes.
And remaining balance,
Yes.
Exactly what I was thinking.
so that we can kind of
Keep track of it.
what we're doing.
We do.
I'm sure you guys have
talked
it.
about whether
Yeah.
we wanted that to be.
Yeah, we can certainly include that. It is something that we discuss in the other meeting that we have before it comes here.
I think
So,
all of us
I
would-
agree with you.
If we're gonna vote on it, we'd like to
Fair enough.
understand what we're voting on,
Fair enough. Fair enough.
because as you know, I'm negative.
I would see potentially at the end of each contingency usage request, maybe putting a note that says, with the approval of these, the remaining owner's contingency and the remaining construction contingency, if that would.
Is that-
Mhm, that would be
is
balanced,
Okay,
yes.
Just the
Mhm.
balance.
Mhm.
Balance before and then
Mhm,
balance after
mhm,
Because
this.
then I can compare each time.
Mhm.
Alrighty.
Thank you, Donna.
If you'd like me to share that now.
Sure.
I could.
Yeah, we're pretty early
Yeah,
on in
if
this
you
whole
have it.
process.
Do you have it handy?
Yeah,
I do have it available. So with these approvals.
Yeah, the being the deduct.
Double check that I have these included,
Right.
bear with me here.
Okay, so I would say, hold on one second. Actually, I'm gonna give you an estimate, because this one's $4,500 off. But, the owner's contingency, is 1.284727. Minus the 4,500, so I'll make sure that I get that updated, for next time. And then for the construction contingency. We are. I know, right? So about $75,000 less than, just because I haven't incorporated the changes, for approval. So, before these approvals, it is 5,285,596, minus about 75,000 for the, sum of all the first three.
Okay.
It's about 6.5 in total, approximately.
Mhm.
Okay.
I'm definitely tracking them separately,
Yes,
because of,
I don't know how it comes out, yeah,
yeah,
absolutely,
yeah,
I just,
yeah.
my brain working.
fair enough.
Okay, thank you, Donna.
And I'll add that to future.
Any other questions for Donna? Nope. And with that, I will accept a motion to approve request 005.
Thanks, we gotta move approval.
Thank you, do I have a second? Thank you, all in favor, Rich?
Aye.
Shelley?
Right.
Sherry?
I,
Now vote aye. Thank you, Donna. That leads us to your next item, which is the general update for our new critical access hospital.
I provided a, written report, I'm trying to, I'll just scan through and see if there's anything that I would highlight. Probably the biggest thing from a construction standpoint really has to do with where we are still waiting for increment 3 permit. We have resubmitted our fourth back check, and the architect has spoken with HCI to make sure that they are doing everything they can, and they have agreed to do everything they can to try and get this, approved. The way that they do it is they have triage, of their, of the submittals, and they're trying to get it approved within triage instead of taking it in and then it getting put to the back of the line for review. So they're working to try and make that happen. Right now, we're getting a lot of cooperation from both the, inspector of record as well as HCI on the oval, but right now the underground, dimensioning is really the thing that is, from increment 3 that we're, pulling forward, in order to make sure that we're moving forward on the construction. Other than that, Sean gave you the summary of the ongoing construction. And we did indicate, or we are indicating in the report about the support services building. We are brainstorming on the best way to rebid this. We ended up rejecting all the bids because they were higher than budget, and we feel like we can get it better in line by taking another look at this, how we're soliciting the services. So we'll be reporting back to you on that plan. And other than that, we are working on outlay requests for March, April, and soon to be May. So those are still under discussion with USDA.
And with the medical equipment, we've gone through, or we finished revising, or not revising, but revisiting all of that, and
We're still, Introvus has all the updates that the team put together as another review of the equipment list. And they are, we have a meeting next Tuesday to go over lab in particular, and then looking to get the overall updated list subsequent to that.
okay, cool. Any questions for Donna? No, no? It's exciting stuff. I
Moving
love going
along.
back there and seeing where it's progressing there back there. Thank you, Donna. Okay, so that brings us then to the Seneca Healthcare Foundation report. And I really appreciate, I don't know if you guys saw the impact report that,
Mhm.
left for us. Very nicely done. I think that all of this is very exciting stuff. I don't have any questions on the report. Does anyone have anything they want to point out or ask about? Golf tournaments tomorrow. Going on, so, yep, they're all getting ready for that, so that's exciting. All right, that moves us on to item number 15, policies and procedures. Our many policies and procedures. Any board members have any questions or comments on these?
Nope.
No,
Okay, and with that, I will take a motion to approve as presented. If they're retired, they're retired. If they're edited, they're edited. Yeah, take a motion.
I motion to approve as presented.
Thank you. Do I have a second? Thank you. All in favor, Shelley?
Aye.
Sherry?
Aye.
Rich?
all right,
I will vote aye. So that brings us to item number 16, medical staff report. See, we have no initial appointments, but we have some VRAD reappointments. Do I have a motion to approve?
I just have a question.
Sure.
Wasn't there an issue with some of the radiology contract?
Yeah.
VRAD, right?
Not VRAD. VRAD is the company, we go through a radiology group that has a contract with VRAD.
Mm,
And so as that group, whatever our decision on that group is, that would, because it's through them, that would put into question VRAD.
Okay.
Their services for us because it's through the current company.
okay.
But in the meantime, there's no reason not to. for that.
Yeah.
So VRAD is subcontracted by the current
Yeah,
company.
correct. Yeah. But yeah, it's
Okay.
what we have right now, but we are working on all of this.
All right, so with that, do I have a motion to approve the appointments?
so move.
Thank you. Do I have a second?
Second.
Thank you. All in favor, Shelley?
Aye.
Sherry?
Aye.
Rich?
Aye.
And I will vote aye. And that moves us into our closed session, government code 54956.9, conference with legal counsel. Government code 37624.3, health and safety codes 1461, and no, I'm sorry, this is a report on quality assurance, so health and safety code 1461. And then trade secrets 32106, reports involving trade secrets. And that we're.
Sherry.
Yes,
Don't hit the gavel.
okay.
One thing before you go into closed session, I'm sorry. Rita. So I am working on next year's fiscal year budget. And we talked in the treasurer's meeting about how I presented to you all the last few years, probably most years, is we have to do it in a separate meeting because it's a lot of information and we just gobble up a regular board meeting. So what was brought up at the treasurer's meeting is that we would look at having a finance committee meeting, which is you, Shelley,
Mhm.
and Rich, or,
Mhm.
okay, you two guys. It's a public meeting. You guys, the rest of the board is able to attend, but cannot
Can't discuss.
directly participate.
Mhm.
So I guess we just want to get an idea of one. Is that gonna work for you guys? Is that an approach that's good for you, Shelley?
Yeah.
Now, the second question is, the date that works so that we have it before the regular board meeting is Monday, June 23rd in the morning-ish. Thinking an hour and a half. 2 hours.
Looks fine to me.
How about 9 o'clock? You can
Okay.
available 9,
Mhm.
because I won't be here. I'm gonna be at my healthcare meeting,
Oh,
so that's the only block of time I do.
okay. Nine's fine.
Thanks.
Thank you. All right, with that, we are adjourned to closed session. All right, our closed session is closed. We're back in open session. By unanimous vote, direction was given to district staff. That moves us on to item number 19, regular board meeting change. We're talking about changing the board meeting to 2 PM instead of 3 PM to accommodate for longer meetings with everything going on with the new bill and all, so, open it up for discussion.
I'm for it.
Yeah.
No, I think that's good. And it'll be easier on staff, cause then we don't have people hanging around
Right.
After hours.
so long unless it's absolutely necessary.
Agreed.
I just let Ethan know, I don't know.
Oh, we started recording again.
Oh,
I think we're good.
you gave Joy the power.
We did.
Oh, dear. Here we go.
So I think it sounds like we may want to do that starting in July.
Well, yeah, I have a personal problem and I'm gonna be at a healthcare meeting. And really can't be involved until 3 o'clock. That doesn't mean you can't start the meeting and, I know we have some key votes. And I wanna be involved with those. That's up to you whether you wanna begin it too, that's fine.
I suggest we started in with the July meeting then.
That's fine.
Does that sound okay?
31st.
July's good for me.
I think
Do I
it's the
have
31st.
a motion?
I move that we change our beginning time for our meetings to 2 p.m. starting the July meeting.
Perfect, everybody, okay.
I second.
Thank you. All in favor, Rick?
Aye.
Shelley?
Aye.
Jerry?
I'm
And I'll vote aye. And you had a question?
Yeah, I think, Brady may wanna talk about this.
Yeah, so, as we're talking about the budget and IT projects of the future, one of the projects from last year that was discussed is getting iPads for the board, so that we can save trees. Deborah and Ethan have done a cost analysis to understand what this costs. And so we put it in as a line item in the board or in the budget for next fiscal year, and it will, as long as the budget is approved and, everything looks good, we'll be moving on that project.
Excellent,
excellent. Okay, Rich.
Yes, I have my own iPad, so unless there's a problem in me using my own iPad, where there has to be.
I would say,
District.
having gone through this with the county, the purpose of having a Seneca given one is that the information is discoverable in lawsuits and public information requests and
That's true.
stuff.
Okay,
So they can show up and take your personal one to go through it and see if you've been doing something.
Security standpoint, we'll probably have certain
Mhm.
software on those.
Yeah, so much as I'd like to save the money, cause I have 3 iPads.
yeah.
But I do know there's a really good.
Well, in the past, I have done that. I brought my iPad in
I have to.
and used, yeah. So
So is
I'm
that,
just in favor of doing away with
I
this.
am too.
It's only an issue, say we were discussing something that ultimately we were gonna be sued on. Then they could, come and, they could come take your computer,
Yeah.
oh, now,
Documentation, yeah.
for that matter. But it just sort of puts a little bit of a firewall between your personal information and computer and, cause if you're like, I am, you use it for everything.
Makes sense.
And that way, if they show up, it's like, here you go.
thank you. Okay, so then I think that then brings us to item number 20, future board meeting agenda topics, which we still need to move up. We were also discussing earlier about having the finance committee meeting,
Yes.
so we'll make sure we get that, so everybody knows when it is and all that, so. Our next regular board meeting will be Thursday, June 26th at 3 p.m. because we will start our 2 p.m. meetings in July. And with that, the meeting is adjourned.
Good.
Thank you.
Oh, that's good.
Good job.
Yeah, I was gonna make a motion that we all